Hi, everyone. I'm Tony Rivera. I'm the Digital Marketing Coordinator for the Christopher Dana Reeve Foundation. I'd like to welcome you to all for this month's online chat with Nurse Linda. Nurse Linda is a leader and provider for rehabilitation nursing for over 30 years and a friend of Christopher and Dana Reeve Foundation for close to 20. Nurse Linda, welcome today, and please take the stage.
Well, thank you very much. It's so nice to be here. I'm here having a very rainy day, so I hope that some of you are having better weather where you are. I know that there's some big storms coming out in the Northeast, so I hope that everybody stays safe and warm there. And just a little reminder, even though your body might not feel the extreme cold temperatures or even the extreme warm temperatures when summertime does happen, your body will still react to that. So remember to keep bundled up if you're going out in the snow or you're in the cold weather. So this month I've been blogging about what happens to you when you have a spinal cord injury or disease. And basically the process is the same for an injury or disease. It's kind of unfortunate because it seems like spinal cord injury gets all the press, gets all the airtime, gets all the public relations information. But in actuality, people who have spinal cord injury disease have the same process that's going on in their body. It's just in a different rate, and it just happens in a different different time frame. But the process is still the same. So I know that a lot of times we talk about spinal cord injury, and in healthcare, when we talk about spinal cord injury, we mean spinal cord injury and disease together. So we don't really separate them out. But I know sometimes I'll hear from people who have spinal cord disease, and they'll say, well, this doesn't really apply to me. But in fact it does, because your disease is creating an injury in your spinal cord. So it kind of meshes together. So I try to be real clear about injury and disease, or injury or disease, just to make sure that everybody knows that we're talking to everyone and not just, focusing on one particular group. There are other people that also have the same consequences that might not even have a spinal cord injury, but they have paralysis from other causes, and in which case a lot of what we talk about on the blog applies to those people also. So if you have any kind of movement problem, basically the blog is dedicated to you. So I hope that everybody gets that sense through that. But in this month's blog, I'm specifically talking about what happens when you have a spinal cord injury, and I tried to make it real applicable to everyone who has any kind of problems in their spinal cord or who has any kind of paralysis. So as you know, whenever you have any kind of injury to your body, and usually what we see are injuries that happen to our largest organ of our body, which is our skin. Skin is actually a living organ. It is the only organ of our body that touches the outside world. And it, encompasses our whole body, so it's a pretty important organ. Sometimes people don't think of it like their heart or their lungs or their kidneys or their liver, because, you can see it, you can feel it, you can touch it. We know a lot about the skin because we see it on us. We know if we get a little cut on our skin, what happens and how that heals up. And the same thing happens to other parts of our body, including the nervous system, if it gets injured. It's basically the same process. So it's easiest to see on the skin if you get a little cut, an opening, maybe you get a friction burn or something on your skin. You'll see that immediately it starts to turn red, and that is because a lot of blood is rushing to that area, because it's the body's natural protection system is to keep out any kind of bacteria, and our skin is our first defense for doing that. So the blood will tend to go to the area where there's an injury on the skin, and you'll see sometimes redness. Sometimes the area of injury will feel warm because there's so much circulation there, and it will swell a little bit because all this extra fluid's there, bringing those cells that are going to destroy any bacteria that's trying to enter the skin. Well, it's the exact same thing that happens in the spinal cord when you have an injury to your spinal cord, either from a traumatic injury or from the disease process, in that extra fluid, extra blood will start rushing to that area, bringing those cells to help protect that area. So it's going to bring this extra fluid to help cushion the area, to help protect it, to bring the white blood cells that are going to carry away any kind of bacteria, anything that shouldn't be there, any dead blood cells or any tissue that's been damaged that it needs to clean up. It's kind of the housekeeping. The white blood cells are kind of our housekeeping in our body. And so the body is, when you have a spinal cord injury, just as if you have a cut in your skin, your body's going to take all these actions to protect itself and to keep itself from having further harm. So it's going to cushion that area. Now the problem is when you have an injury in your spinal cord, that spinal cord is housed in the bony vertebrae. So people sometimes get confused that the spinal cord is actually a bundle of nerves that runs down the entire, from the brain all the way down through those bones of the bony vertebrae. So the spinal cord is running through there. It's about the size of your thumb. It's kind of large, I think. Sometimes it doesn't seem like it should be that big, but it's about the size of your thumb, and it's about the consistency of a Jell-O jiggler. So we've just had the holidays, and there's a lot of advertisements for Jell-O jigglers for the kids. You know, it's like a real thick gelatin, and you can kind of poke at it, and it doesn't fall apart like regular Jell-O, but it'll kind of jiggle. So if you hit one part of the spinal cord, it'll kind of jiggle. And then because it's housed within those bones, there's only enough room for the spinal cord and the fluid that bathes the spinal cord that's protecting it normally. That's all there's room for in there. So if you get an injury either through a traumatic injury or through disease, this extra fluid is going to run to the spinal cord, and so it's going to create some swelling in the spinal cord. But since it's in that bony casement of the vertebrae, there's no place for it to swell. So that creates a problem because the only thing that can happen is that the spinal cord gets constricted because of the swelling, and the only place for it to constrict is to shut down in the center of the spinal cord. So people who have spinal cord injury or disease, they generally get a little hole in the center of their spinal cord, even if it's a bony fracture that has pushed up against the outer edge of the spinal cord. It's still going to collapse in the center. That's where the damage is going to be done. Now, if you have disease, it's slightly a little bit different in that you can have some damage to the actual nerves that run along the outside of the spinal cord, the outer edge of the spinal cord. So you can have some damage done to those. Even in trauma, some of those nerves might become discommunicated from the bottom of the nerve. So there might be a little cut in that one or two or in several of the nerves, but there are many, many nerves in there. So the big take-home message is that even if you have disease or if you have a traumatic injury, your spinal cord will not be severed. There might be some nerves in there that might be damaged, or the myelin, which is the protective sheath along those nerves, might have some damage to it so that the message cannot connect and transmit correctly across the nerve. But the damage in the spinal cord itself is going to come in the center of the spinal cord. So there's a couple of things that are going on there. So that's probably the simplest version of what happens when you have damage to your spinal cord, but it's very important. And it's very important to know that that is the way it happens because of the way that we classify spinal cord injury. And I hear lots and lots of patients, and rightly so, because you're hearing this information about your spinal cord at a very delicate time in your life. It's very traumatic to hear these words spoken to you. And so it's a lot to take in, besides the fact that you've had an injury, you don't feel well, you might have other body injuries, or you might have a disease that's affecting other parts of your body. So it's not like you're at your peak of perfection when you hear these words about spinal cord injury. So it's a real challenge to take in all the nuances. There's a saying in healthcare that people only remember 20% of what's told to them when their clothes are off. And in healthcare, it's one of the few professions that you can say to somebody, please go in this room and remove all your clothes, and people just do. And because, it's an expectation, but there's not very many other places where you go and remove your clothing. In fact, I can't think of any. So anyway, it's very difficult to be, you're sick, you've had something horrible, catastrophic has just happened to you, you're getting information about a disease that you may have, or you're getting information about an injury that you have to your spinal cord, and you're naked, and you're vulnerable, and you're laying in a bed and everybody else is standing up over you. So it's a very, very difficult time. There are just so many factors in here. So people only really retain about 20% of what they're told just when they go for a regular doctor's visit. So imagine, as you've experienced all of these things going on, all of a sudden you have somebody explaining the spinal cord injury to you, and you're like, oh my goodness, this is a lot to take in. So the way that the spinal cord injury is categorized is there's a scale of A to E, so A, B, C, D, and E, and they're each different category for how to describe your injury. So when a person gets injured, they'll do X-rays, MRIs. They'll know where the injury is. If you have a traumatic injury or if you have a disease, they'll test your body by doing imaging studies and look to see where that disruption in the spinal cord injury is. That is going to be the level of your spinal cord injury. They can also do tests, and I'm sure everybody's had the tests where they do the manual muscle movement, and they go through each dermatome of the body, and they do the little pinprick test and the light touch test with the cotton swab, and they'll say, do you feel this? Do you feel this? How do you feel? Does it feel normal? Does it feel kind of asleep? But you still feel, they'll ask you all kinds of questions. So it's a very, very complete test. Now, the dermatomes are each level of the body is being tested, and a dermatome relates to the level of the spinal cord where the nerves are coming out to control that part of your body. So up in your neck you have nerves that are coming out that are controlling your arms and hands, and as you get further down in the body you have nerves coming out at each dermatome. They're coming out at each of those bony vertebrae. There's a set of nerves that come out on each side and wrap around your body, and those are the nerves that control that part of your body, and it goes on down through your legs. The very last nerves that come out are the nerves that control bowel and bladder. So that's why they're so important, because they're the last ones that come out. Okay, so you've got this picture of the level of your injury, and that will be classified by the cervical region, thoracic, lumbar, or sacral region. And you can remember how many nerves are in each by thinking about dining time. So you usually have breakfast. Most people have breakfast at 8. So if you think about 8 o'clock, oh yeah, there's 8 cervical vertebrae. There are 8 connecting dermatomes to those. Actually, the first one is up in the brain, so you can't really test that one because it's up under the skull. So you can't really test that one. But then you go down into the thoracic area. Those are the vertebrae that have ribs attached to them, and there are 12 of those. And you think, oh yeah, most people eat lunch about 12 o'clock, so that kind of helps you remember. And then the lumbar is in the small of the back, and then the sacral is kind of like what looks like that shield right at the end of the tailbone. Those each have 5 vertebrae in them. So if you think about dinner times at 5, the last 2 sections are at 5. So it's kind of an easy way to remember it. So that will give you the level. And then they'll do these tests to decide what type of injury you have. Now, a level A, so you might have like an injury at T4 with an A after it, indicating the type of injury that you have. And that type A injury is called a complete injury. And this is where I think a lot of the confusion comes into play, is because people are told at this most horrible day of their life, and they're told you have this level of injury and it's a complete injury. It's an A-type injury. And so people will think, oh my gosh, I have a complete injury. I've completely severed my spinal cord. This is not true at all. And so this is the real important thing to remember, because if you have a complete injury, that means that there's just no sensory or motor function that is going down all the way down to those sacral segments, those last ones in the sacrum at S4 and 5. There's no function going through there. It has nothing to do with completely severing the spinal cord. Now, I hear patients talk about complete injuries thinking they've completely severed their spinal cord, which they have not. And I hear healthcare professionals that don't deal with spinal cord injury a lot, I hear them talk in the same way. So that information is being communicated to a lot of people. So if there's one thing I like for people to know is that hardly anybody ever has a completely severed spinal cord. In 40 years, I have not seen a completely severed spinal cord. I've seen some people maybe who've had some surgeries that have completely severed their spinal cord, but it's so very rare. And we all know that it probably happens if somebody gets cut, if they have a knife injury, if they hit their spinal cord completely cut by a knife, or if they maybe have a bullet that goes straight through, but the odds of these happening are just so incredibly small. So very rarely do people ever have a complete severing of their spinal cord. So there is always hope for recovery because there's always spinal cord attached. I have a very dear friend who had a very significant spinal cord, and you can see on his x-rays, you can see the damage. There's a little of his spinal cord left that's completely attached, but he still has some fibers that are attached. And remarkably, this is one of those most unusual cases because this person walks around and if you would look at him, you might think, well, he kind of walks with a little limp. But when you look at his x-rays, you think, how can this possibly be? So it does not take very much of your spinal cord to remain intact to regain function. So always keep that in mind. Now, the downside of that is we haven't quite figured out how to harness that for everyone. But we're getting closer and closer to it. So that's the important thing to remember. Now, if you get classified as a sensory at a B level, that's a sensory incomplete. So you have some sensory but no motor function is preserved below the neurological level. That's the level of the spinal cord, the cervical, thoracic, lumbar, or sacral. And it includes that those very last nerves that come out at S4 and S5. So you have some sensory, but you have no motor function if you're sensory incomplete. Okay, if you're a C, you're motor incomplete, or you have some motor function below the neurological level, but most of the key muscles are less than a grade 3, which means you can't move those against gravity, but you still have some movement. And then D is, again, is motor incomplete, but in this case you have some movement that you can move against gravity. So there's a slight differentiation between C and D. And then a person who is classified with an E type of spinal cord injury actually has had a spinal cord injury, but their sensation and motor function is for some reason not disturbed, or at least not disturbed enough that it shows up really on these tests. You might have some deficits, but you're still pretty functional and have some sensation. So sometimes we see people who've had a spinal cord injury, maybe they go into spinal shock, but when they come out of their spinal shock, they're able to function pretty much as the way they were before. And that's a person that we classify as E, that they have pretty much typical function as they did before, but in fact they actually had a spinal cord injury. it's one of those shades of gray that you have to distinguish, because sometimes you'll see people, especially on TV, football players who are very keenly interested in spinal cord injury because you see it on TV. Their bodies get thrown a certain way, their neck gets moved a certain way, and they end up having a spinal cord injury. And you see that happening. So it's pretty rare, but it's not all in all that unusual. So a lot of people who are in the football sports or rugby sports, those real aggressive body type sports, are very interested in spinal cord injury and protection and how to avoid them. Sometimes those people will have they'll get hit. They're taken off the field, and everyone's quite concerned. They're not showing movement, but sometimes they have what's called a stinger, and that's a little tiny spinal cord injury, but the body's able to overcome it. This E level, being normal, is a little bit different than a stinger in that the spinal cord injury was more than just a little tap and then the spinal cord recovers. There's actually some damage done to the spinal cord there. So shades of gray there on how to classify those types of injuries. But the important thing to know is that everybody who has a spinal cord injury has a significant chance of recovery. So after someone has a spinal cord injury, and again, it's easy to slip into the idea that we're just talking about trauma, but we're talking about disease also. And so I think that people look and study trauma more often, because when a person has an injury in their spinal cord from trauma, it's almost like a natural experiment. If you think about back in your high school days when you were studying biology, and one of the classic signs of an experiment is control. You want to know exactly what happened, when it happened, how it happened. And with trauma, you have a lot of built-in controls. So you have a really good idea with the way our EMTs and our emergency systems are now, and the way that we can call 911 and help is very quick ready to help people who've been injured in accidents. So you have a lot of natural control with spinal cord injury. You almost know down to the minute exactly when that injury occurred. A lot of times you do know actually to the second when it occurred if it's a witnessed trauma. You know what vertebrae are injured, so you can get that from the x-ray. You know what the outcomes are. You can classify things by these levels and by what level the vertebrae is injured. So that coordinates with the spinal cord injury. So you have a lot of information that's immediately gathered, and you know there's no other factors that are impeding on this particular spinal cord injury. Now with disease, it's a little bit different, because you can have a spinal cord injury from a variety of diseases, but you don't really know exactly when the disease started. And you might have different points in the spinal cord where there's some abnormality, but it's not really maybe fully evolved yet because the disease is still evolving. So you can see you have a lot of different controls that are lost with disease. So that's what makes it a little bit more difficult to predict with the disease. So diseases like multiple sclerosis, people think of that as it is a neurological disease. A lot of times people think of that as a disease in the brain. But in actuality, more of the deficits come from the multiple sclerosis affecting the nerves in the spinal cord than actually in the brain. It's kind of an interesting phenomenon that way. So it's difficult to say if somebody has multiple sclerosis exactly what day and what minute did that disease start, because you don't really know until the disease advances enough that you start to have the deficits. And then you say, well, I've had the deficit maybe for like a month before I came to the doctor, but did it start then, or did it start a year before that, or 10 years before that? We don't really know. So that's why it's kind of more difficult with diseases. You might have deficit at the T2 level, but you also might have a deficit at the L4 level. So it's a little, you've lost a lot of these controls in the diseases. Guillain-Barré is another one. There are many diseases that affect the spinal cord because it's part of the central nervous system, the brain and the spinal cord. So anything that can, a disease that can affect the brain can affect the spinal cord. Some people have a stroke in their spinal cord. We always think of a stroke as being just in the brain because that's where we most often see it, but you can have a stroke also in your spinal cord. So there's a lot of unknown answers to injuries with disease. But the good news is that all the research that goes into spinal cord injury from trauma with all those controls, once you've got that, figure out some of the keys to the traumatic diseases, you can translate that to people. Once you have the keys to the trauma, you can translate that to the diseases. So you can kind of take that information and discoveries and apply it to disease with paralysis, with resulting paralysis. On the other hand, a lot of the information and the research that's being done within these particular diseases is also applied to the traumatic injury. So it doesn't matter where you get the information. The key is just to get the information. Once you get the information, it helps everyone who has any kind of paralysis. So that's ultimately the key in what we're trying to do. Now, if you have a spinal cord injury, it usually comes in two phases. We have what we call the acute phase, and people are usually classified in the acute phase for 6 months. And so then after 6 months, people are classified then as having a chronic injury. Now the 6 months is kind of an arbitrary phase, but usually people have the most return of function in the first 6 months, and the reason for that is within hours of having a spinal cord injury, people will usually enter into what they call spinal shock, and so their body is trying to protect itself, it's trying to conserve the energy, and so the spinal cord is not really representing the full use that it has because it's in the spinal shock. So it's shutting down, it's quieting itself, it's trying to rest for a while, and so you don't get a lot of the reflexes, and you can't really tell the extent of what's happening when a person goes into the spinal shock. And the spinal shock can last between 2 weeks and 6 months. That is a long difference in time. So some people come out of spinal shock right away. Some people take a lot longer to come out of it. But usually after about 6 months, you kind of see where you are with a spinal cord injury. Now with disease, it's a little bit different because people don't go into this sudden spinal shock. It comes on much slower because disease evolves much slower instead of this huge just sudden trauma one day. And so sometimes people with disease might go in and out of spinal shock at various times and at various degrees, or they might not even go into spinal shock at all. It might just be an ongoing kind of thing. So as we go through this first 6 months is kind of a wait and see. We try to keep the body as healthy as possible, try to keep everything flowing and activated as much as possible, and then we wait and see what happens. And so after about 6 months, when you enter into the chronic phase of spinal cord injury, that's when people really kind of know where you are with your injury. When you have disease, you kind of just enter right into this chronic phase. So it's kind of unusual in as far as diseases go because you have this two-part process. Now, there used to be, and I know some of you probably have heard this in the past, and it was repeated to you because it's what healthcare professionals believed, But, and you might still be hearing this now, some people who maybe don't have access to spinal cord injury treatment by specialists might not know about these kind of things. But it used to be that we used to tell people, well, in 2 years we know exactly that's where your spinal cord injury is, that's where it's going to stay, and that's what you have, which at 2 years was the time. Well, when people started looking back at that and studying, really getting into studying spinal cord injury, which has been after World War II, and really there's been a great increase in the study of spinal cord injury over the last 20, 25 years. It's really propelled itself, the studies propelled itself forward. So when people would look at that 2-year landmark, they would go back and they'd be like, 2 years. Now why 2 years? Well, what they discovered was that researchers studied individuals with spinal cord injury for about 2 years, and after 2 years they didn't see any return of function, so they said, well, that's it. We've looked at it for 2 years. That's long enough. But what we know now is that people are having return of function all the time. And it doesn't matter if it's 2 years or 5 years or 10 years. The body is constantly attempting to heal itself, and so some people will have some return of function years and years later. And so this is an important thing to remember. So there's a question about spinal shock, and it's, the question is, in spinal shock, is there still ongoing damage? Well, in trauma, the damage occurs when the damage occurs, and generally speaking, and I would say most often now in our advanced thinking world, I guess, with access to good health care, people who have spinal cord injury are usually taken to a hospital where treatment is provided, and there usually is not further injury after the cord has been stabilized. So after a person's had surgery, maybe they've had some plates put in and the cord is stabilized, typically there is not further injury that is going to occur. The vertebrae have been stabilized, so it's holding that's on there. Now, there's a lot of swelling that's going on inside that spinal cord because that's what the body wants to do. It wants to provide extra fluid because it's getting itself better, but it doesn't have the resources to think, oh, wait a minute, it's in this bony case of the vertebrae, so if I swell, there's no place for the spinal cord, the extra fluid to go. So then it has to collapse on itself. So a lot of diuretics and different medications, usually some steroids are given to reduce this swelling. So generally speaking, there's not a continuation. There might be a natural progression of the trauma due to the swelling, but generally the healthcare is today that much of that is reduced. There still are some secondary problems that can occur that will continue because of, the effects of the spinal cord injury. So there might be breathing problems, there might be cardiac problems. There can be all kinds of things because all those messages that need to travel through the body to get to the major organs are not being able to get through. So there oftentimes are some secondary, what we call secondary complications, which can include low blood pressure, or the heart rate can be particularly slow. Over time, the heart rate will slow down and slow pumping of the blood through the body. Sometimes the heart rate pumps up right after the injury and it starts beating much faster because it's trying to get the blood through the body. And so, the body's trying to react and how it knows how to react, but it's reacting because it's not getting the message that says, okay, body, slow down, take your time, everything's going along fine. So there's all these secondary type of things, and there actually is a question about with spinal cord edema, hemorrhage and decompression surgery could be possibly be beneficial for secondary injuries, and it really depends on the injury itself. Once the things have been, if the bony vertebrae is pressing on the spinal cord. And if that has been removed, that's the decompression. And so usually by the time they control this edema and hemorrhage in the area of the spinal cord, usually that then is taken care of. Now there is a complication that can develop much later after the spinal cord injury. And as I said, because of the compression, the spinal cord is going to collapse on itself, creating a hole in the middle of the spinal cord. And so sometimes that hole sometimes can get filled with fluid, but it's much later. It's not right after the injury. It's usually much later, and it's over time. So people are pretty stable at their level of injury, generally speaking, unless they're getting recovery because their body's trying to recover. So people will be pretty stable, or they'll be getting a little tiny bit return of function, hopefully a lot of return of function, but they might see some different returns. And it usually starts out with a little bit of return and then you learn to use that, and so you can harness that into larger returns of function. But over time, and it's usually years later, that syrinx, or that little hole in the spinal cord, might get additional fluid, which might fill and press on the top or the bottom of the spinal cord where that injury is, where that hole is. So if you start to lose function, you want to get to your doctor right away and have that spinal cord assessed, because they might need to drain that. You really need to go to a specialist. It's a difficult procedure, so you need to go to somebody who does this all the time, or at least has done many of these, because I don't think anybody does it all the time because it happens so rarely. But you want somebody who's really experienced in draining these syrinxes, because you have to go into the center of the cord, which means you have to enter that through that nerve fibers on the outside of the cord. So you want to be sure that you don't have more damage from doing this drainage of the syrinx. But you can lose a lot of function with that. So that's one of the things that's happening. So these are the kinds of things that you need to look at, but that's further out. Right at the time of the injury or at the time of the disease. Now, if you have a disease, you might be losing function. It doesn't mean you have a syrinx. It could be just the progression of the disease. So you just want to watch. What we want to do is to maintain people's function, and we want to improve their function. That is our goal in rehabilitation. So these are the things that we actually want to accomplish. Now, I see a lot of people that come from lovely places. They've had excellent rehabilitation care, but maybe they've been to a place where people don't take care, or they don't see that many people with spinal cord injury. They've had excellent therapists and they've had excellent care, but they're kind of scared of hurting themselves or moving. They don't have the confidence. I see people sometimes come to clinic and their arms are on arm supports, and they're Velcroed down so their arm does not fall, which, the weight of your arm can pull it out of your socket if you don't have good shoulder muscles. So they're all prepared for any consequences. But the reality of it is perhaps they have a little more function than was thought originally. So sometimes it's a good idea to just have a reassessment. If you have the chance to go to a specialist that deals with spinal cord injury to get an evaluation, maybe it's a special trip, just a one-time deal to go see that particular doctor, who can then send recommendations to your regular doctor if you don't live close to a spinal cord specialty center, or if you don't have spinal cord trained therapists or nurses. It's a good idea if you have access, if you can, at least see a specialist one time or maybe even once a year, to kind of get the latest on the updates, what's going on and what's possible for you. There's so many things that are going on in the world treatment of spinal cord injury for people with traumatic injury and for treatment with diseases. There's just an abundance of things that are going on right now with treatments and things that you can do to help yourself and to help enhance your recovery. So I was fortunate enough to get to work with Christopher Reeve, and when I had first met him, he and his wife Dana would kind of laugh. They call this his party trick, that he could kind of sort of move one finger, and they just called it his party trick. And this didn't develop till like years after his spinal cord injury, and certainly after the 2 years when they used to be watching that. But he called it his party trick, and he could move this one finger. That was from his own body's regeneration. That just happened spontaneously. But once we had that movement in the finger, then we were able to harness that movement into other things that he could do. So we knew his body was regenerating, and he went heavily into this activity-based program, and it was very beneficial to him. He had wonderful success with that program. So he was classified as an Asia A, which meant he had completely no motor or sensory below his level of injury, but he got changed to a classification of motor incomplete, in that he could move every joint in his body, but not all of them against gravity. But he could move every joint in his body. And he did that through activity. Now, he was a special case. He was a research study where he was the only person in the study. And it was at a different time in history where people weren't quite sure what to do with somebody who was having recovery. So we just did everything to see what, it's kind of like cooking spaghetti and throwing it on the wall to see what sticks. Let's just give him everything and see what happened. And so he was on his way to quite a good recovery. Unfortunately, other things caught up with him, but he was on his way to a very good recovery, and it was very impressive. Now those treatments have been studied by a variety of healthcare professionals and researchers around the country and around the world. And one of the things that has come out is a study that's being sponsored by the Christopher and Dana Reeve Paralysis Foundation, called The Big Idea, where instead of doing the stimulation to the outside of the body, there's an implant that's going in along the tract of the spinal cord that makes that leap over the injury. And they're having some great successes with that. Is it perfect? No. Is it a lot more than we had before? It's huge. So this is a great study that's going on. And there's also some other studies that are going on all around the country. So it's a really exciting time to be working in spinal cord injury at this time. So we do have a question about is there any surgery that allows for more cord swelling? It says she has a family member that was moving but was weak when he went to the trauma center, and then after being transferred to the telemetry floor, he coded and went into respiratory failure, and so then he looked more like a TBI patient. So now he's having some severe problems. So it sounds like this is one of those situations where something happens and then there's just this whole sequence of events, just one thing happens and then another happens. So if he had respiratory failure, now I don't know this case, so I'm only just going to talk from the knowledge that I have, not particularly about this patient, but if he had respiratory failure, he could have some brain damage from that respiratory failure in addition to his spinal cord injury. Or perhaps he wasn't breathing effectively. He was breathing but not effectively, not strong enough for a period of time. Or since he was on the telemetry, I have to think that they were thinking something was happening with his heart, and so maybe his heart wasn't beating effectively for a period of time, which could lead to lack of oxygen getting sent up to the brain. And since he coded, it sounds like this was a pretty significant problem. Would it have made a difference being on a telemetry unit versus being in the ICU? That would be an impossible point to prove, I do believe, because the telemetry is still having the same monitoring as you would have in the ICU, so there should be the same sort of responses. he looked more like a TBI patient after 4 days, and that's probably perhaps from some anoxic injury due to the cardiac failure and the cardiac arrest. That's a code as a cardiac arrest or respiratory failure. Somebody's heart is not beating, or they're not breathing, or both is what a code is. Okay, so now in 10 months he's quadriplegic and he's severely contracted and he has severe bed sores. So this is a problem when you have a spinal cord injury. Sometimes your muscles get out of balance. Even though you don't feel like they're working or you can't control them, we have two sets of muscles that do everything. So for instance, just in our forearm, we have muscles that will pull our forearm towards our body, and we have muscles that pull our forearm away from our body. So we have muscles that move our body parts in one direction, and we have muscles that move our body parts in the opposite direction. So the muscles that pull our body parts towards us are always stronger naturally than the ones that pull our body parts away from us, because when we're pulling away from us, gravity is also taking hold. When we're pulling towards us, we're working against gravity. So that's why our muscles that pull towards our body become stronger. When we're pushing our arm away from us, gravity helps pull our arm down. So those muscles are always a little bit weaker. The same thing happens in your leg. If you think about your lower leg, you can pull your leg up back towards your body. You can pull your thigh up towards your abdomen. So we have all these muscles in our fingers and our toe, everywhere they do the same thing, those that pull and those that push. Okay, so that's what happens with the contraction, is that those muscles pull too tightly. What can help prevent that from happening is to do the range of motion exercises to keep the muscles pulling away from the body, to keep those muscles strong and to help counteract those muscles that are pulling tightly towards the body. Once a contraction has occurred, that means that that muscle has either spasmed and is maintaining that tight pull towards the body, or else the muscle has shortened so that you can no longer extend it. You can also early on, you can use positioning to keep the muscles stretched out so that the contraction hopefully will not occur, and usually they don't when you position and do range of motion. So his muscles have severely contracted, which is a result of the spinal cord injury, but also can be heavily influenced by the traumatic brain injury, so from the head injury also. Now, you can still extend those contracted muscles. Sometimes people will use Botox, and that will relax the overpowering muscle. So that will relax it a little bit so that you can then stretch that out. And then special splints will be applied to hold that arm and leg and hip and shoulders, to hold them into position. Also, sometimes there's surgery that can be done to release those contractures, to pull them out. Contractures can be potentially painful if you have sensation. They can also prevent a person from conducting proper hygiene. It's very difficult to open if a person's arm is contracted and you want to clean inside the elbow, if the arm's contracted, you might not be able to get in there, or in the hand. You see a lot more contractions with people who've had stroke, and they'll have the one side of their body might have contractures where their hand is in a fist position and you can't open their fingers, and then their wrist is turned in and their elbow is up. So the same thing happens if those muscles are not tended to and range of motion is given. The other thing is this person has severe bed sores, and bed sores can come from a couple of things. One is not laying on a pressure reducing surface. So there's special equipment that you can buy, mattresses that are pressure reducing, pressure dispersing. That dispersion is an important word when you're picking out a bed surface or a wheelchair seating system, in that wherever you have bones that are near the surface of the skin, you can have skin breakdown, because when we're without a spinal cord injury, without a head injury, we tend to move our bodies thousands of times every hour, just little nuance moving, little shift in weight. But when you don't have that ability to move yourself, or when you don't feel that your weight needs to be shifted, I mean, normally we just move our bodies just almost imperceptibly sometimes, or in bed we'll roll over to get pressure relief. But if you're not able to do that, or you don't have that sense that you need to move, where those bony prominences are close to the body, you can end up with a pressure sore if you don't have a pressure dispersing surface, because that bone will pinch the skin onto the hard, regular mattress surface and cut off the circulation there, and that's why the pressure sores occur. Now, if you've had a problem with your diet, if you're unusually thin or if you're unusually heavy, you have a higher chance of getting pressure sores. If you're not eating a healthy diet, giving your body tissues all that nutrition that they need, you can have an increased risk of pressure sores. So people who are very thin don't have much padding between themselves and their bony prominences, so they tend to break down a lot. People who are heavy have a lot of fat in between their bony prominences, and their skin and fat is not pressure dispersing. People like to make the joke, oh, it's okay, I fell down, or I have a lot of padding back there, when they're talking about their rear end, but fat is not padding. It does not disperse the pressure. It just holds it right there in that spot, and it's just like an extra constriction around that bony prominence. Another thing that leads people to have a high risk of pressure sores, besides their body type, if they have a problem with drugs or alcohol, or if they just haven't had good nutrition for a while, that tends to break. If you've been sick in the ICU and you've been on some kind of special diet, or maybe you've just been on IVs, you should have all the proper nutrition. They check for all of that to make sure it happens, but sometimes people just don't get, they're metabolizing differently because of their injury, and they don't get all that nutrition to those sites. So pressure sores can be healed. They need to be they're depending on the level of the pressure sore, what stage it is, if it's stage 1, stage 2, stage 3, stage 4, or if it's unstageable so that you can't see what the stage is. There are treatments for each one. Some really severe pressure sores will need surgery. Now, when you think about surgery, if you have to have it, you have to have it, and that's just all there is. That might be the only way to heal up that pressure sore. But once you have surgery, you've made a cut in the body, and what's the body going to do? It's going to make a scar, and it's going to make a scar through all the tissue that's been rearranged to get to the bottom of the bed of that pressure ulcer, to get that healthy tissue up so that can heal. So whenever you've had any kind of pressure sore, the skin on the top is going to be healed. It's going to be scarred. It's not going to be as elastic as your natural skin was. So you have to be really careful after you've had a pressure sore, because your risk of developing a second one in that same spot is going to be higher. So you really want to make sure you have pressure dispersing bed surfaces and seating surfaces. And even though you have that, your body still will need to be turned every 2 hours, or maybe even more frequently. You also need to be kept clean and dry, so you need to have a good bowel and bladder program in place, so that the moisture and any kind of dampness, moisture, any kind of dark areas like in your gluteal fold, or sometimes people get pressure ulcer even though there's not a bony prominence. If they have a little bit of a pendulous belly there that's laying on their thighs when they sit, sometimes people get pressure ulcers in there. You can take a small washcloth and roll it up and separate that skin so some air flows through there. But moving your body so that you have different positions so that you take the pressure off of those sites is going to be helpful. So one of the last things I did, my blog for this week was looking at the new year, and I always like to look at resolutions. And so 3 things for the new year that I think are important for anybody who has any kind of spinal cord injury from or disease is to take deep breaths and stimulate a cough that keeps your lungs clear and keeps your breathing, your respiratory system in good order. As a person who does not have a spinal cord injury, I do this sometimes, especially in the cold and flu season, where I'll take a couple of really deep breaths in. Now you don't want to do it so much that you get dizzy, but just take some really deep breaths way into the bottom of your lungs. So using all your lung muscles and down into your abdomen, using all those muscles. And after about 2 times of doing that, it really kind of just makes me cough anyway. But that cleans everything out of your respiratory system and it moves any bacteria in there around. So it's a good idea to do that even every couple hours while you're awake. If you have a spinal cord injury and you have mechanical ventilation, you might want to use the cough or sigh button to get some extra air moving through your lungs. If you have a lower level injury, you might still have some problems with some of the muscles, especially down in the abdomen. So it's important to do that to keep your respiratory system clean and clear flowing. Coughing will help move, if you have any mucus in your lungs, kind of help unplug that. So it just helps clear things out. Another thing is to wash your hands thoroughly, and this is going to be a very important thing. Again, this is something anybody can do. If it's you with a spinal cord injury or your caregiver, have them wash their hands. Now, it's wintertime and our skin becomes dry, and you might want to use an emollient lotion after you wash your hands to keep your skin moist because you don't want any cracks in your skin letting that bacteria in. But wash your hands thoroughly. Sing happy birthday or say the alphabet while you wash your hands. Do it twice. Use warm water. Use soap. Use a lot of friction of rubbing your hands together. Rub the back of your hands, the palms, your fingers. Your fingers have 4 sides. They have the top, the bottom, and 2 sides. Rub all of those, work around your fingernails. There's a lot of bacteria, a lot of fungus likes to hide in there. So if we keep our hands clean, that helps us transmit less germs. And then the other thing to think about during any time of the year, and again, good for everyone, is movement. And so you think, oh, I move all day, I'm pushing my chair. And that's all true. That's a lot of good movement, a lot of good exercise for your upper body. But if your lower body does not have movement, you'll want to take your legs, pick them up, range them, be very gentle with them. Remember, you don't feel what's going on, but your body's still going to relax. It's still going to react to what's going on. So don't try to push past your joint limits, but range through the full motion of the joint. Carefully move your legs, pick them up, move your toes, move your ankle, rotate your foot around. If you can do any of this yourself, actively, go ahead and do it. If you need to do it passively, by using your hands to move your legs and move your joints. Don't forget that when you're seated in a chair or when you're laying on your back, that's when most people do their exercises, laying on their back in bed. But you can't go below your body, where your body is, so you can't move things to the back. So roll on your side so you can stretch your hips out. When we sit in a chair all day, if we have an injury or if we don't have an injury, and this lady has this family member with a contraction, when you sit in a chair all day, sometimes people get contracted hips because they're in that 90-degree position sitting in the chair. So be sure, if you can, take a rest, get out of the chair during the day and stretch those hips out. Lay on your side, move your leg back a bit so that you've got a little bit of counter motion for that seated position. and move as best you can. If you do any kind of exercise, if you play any kind of sport, if you do any activity-based therapy, continue to do that. We're going to see a lot more improvements with activity. You know, back in the days of the polio epidemic, so like in the 30s and 40s, the thing that seemed to help people who had polio, which is paralysis, it's a movement disorder. It's affected in the spinal cord. And the thing that we would see with this muscle weakness of polio is that there were treatments that were developed with a lot of movement, just moving of the joints. So your body is always trying to heal itself. So any input that you can give to the part of your body that doesn't have any kind of movement or sensation, or maybe has very little, then you would be able to stimulate from the body up to the brain while you're thinking about moving that body part. While you're doing it, thinking about if you're if you're moving your toes with your hand, think about moving your toes with your brain and try to make that connection. That seems to help to make those connections between the brain and the body. So these are just things to think about. There's one more question on here that I really wanted to get to, and this is a person who has had an injury for 5 years and has been diagnosed with 7 bulging herniated discs. Is this common? Well, herniated disc can be from people who don't have spinal cord injury. We all know about that. Could it be from your injury? Well, it could be something that's happened from that. If it's just above or below the injury, if you have hardware that's put in, then those vertebrae where the hardware is, or that hardware where the vertebrae have been fastened together with the hardware, those vertebrae now don't move. So sometimes what happens is right above the level of injury or right below the level of injury, people tend to have these problems with herniated discs because that vertebrae, each of those vertebrae, there's so many because they all move when your body moves. They move at different degrees depending on what you're doing. So if you fuse some vertebrae together, either with a bone fusion or if you have a plate in your back, sometimes people will have problems with disc right above or right below because the vertebrae right above or right below is overcompensating for those that don't move. So is it common? Not really. Does it happen? Yeah. So I'm just thinking that that's probably that those herniated discs are right around maybe where your injury was fused perhaps. And so that sometimes happens. So with that, I'm going to have to say goodbye for the day. I thank everybody for listening. I hope it was helpful. And I'll turn it back to Tony. And thank you, everybody, for tuning in today.
Thank you so much, Nurse Linda, for today. I just want to thank everyone for joining us today. This presentation was recorded and will be archived by the end of the week for viewing at youtube.com/Reeve Foundation. Hope everyone has a great 2017, and take care. Thank you, Nurse Linda.
Thank you.